Okay. Well, as I said, good afternoon, everyone, and welcome to teaching today. I wanted to talk today about how to read a paediatric ECG. So we've done sometimes do this teaching in person where we go through some ECGs, but I just thought I'd talk about the theory around how to read a paediatric ECG and a simple way to do it. And I think if you know the system to do it, then you can practice it when you do ECGs. And I know there's been some ECG machines recently bought and being used in the emergency department and elsewhere. And I think it's just good to have a system to read pediatric ECGs because they're actually once you know the system, it's actually quite easy to do so. So I hope this simple system that I'm going to try to teach you today it probably will be familiar to you. Much of it will be familiar to you, but also will be an easy way that you can learn how to read a pediatric ECG. Mostly pediatric ECGs are similar to adult ECGs. There are some differences that relate to developmental changes in systemic vascular resistance and the dominance of the right and left ventricle in the first year of life, but mostly they're similar. But they're different in as much as pediatric cardiac lesions are different to adult cardiac lesions, but there's some overlap. What's important is understanding actually the underlying principles of the ECG. So I wanted to talk a little bit about the underlying principles of the ECG, because I think if you understand that, then you can really understand what the ECG is. And so important to understand how the ECG relates to like electrical conduction through the heart and how it relates to the cardiac cycle. If you understand those two things, the flow of conduction of the electrical activity through the heart and the changes in the ECG with the cardiac cycle and what the different parts of the ECG means to the different parts of the cardiac cycle, then you're really on the way to understanding the ECG. So you all know that the ECG starts at the pacemaker fibers in the sinoatrial node, which is up in the right atrium. Now, if you've got that initiates the P wave. So here you've got atrial depolarization. Atrial depolarization means a positive electrical conduction of electrical activity through that part of the heart. So atrial depolarization is the beginning at the sinoatrial node, and then it the electrical activity transfers across to the left atrium and down to the atrioventricular node. So the P wave is atrial depolarization, and then the time between the start of the P and the start of the R wave or the start of the Q wave is how long it takes the electrical activity to get from the sinoatrial node to the atrioventricular node. Right? It's as simple as that. And so anything that delays the conduction through the atrium will cause a long PR interval, right? Anything that causes anything that causes the atrial depolarization to be prolonged may cause a prolonged P wave, right? And so if the muscle is extra thick or if the atrium is extra large, then there'll be an abnormal P wave and there may be a prolonged PR interval because it just takes longer for the electrical activity to get to the sinoatrial node. After the sinoatrial node, there's the bundle of, they're just smaller fibers, smaller electrical fibers that branch out throughout the whole of the ventricles. So the bundle of His goes into left and right bundles. And so the right bundle innervates the right ventricle, the left bundle innervates the left ventricle. And then you have these things called Purkinje fibers, which conceptually just go around the ventricle and innervate the myocardium of the left ventricle and the right ventricle. And so if you remember it like that, some of these things will be familiar. If you've heard of the right bundle and the left bundle, and when you've got a right bundle branch block or a left bundle branch block, then simply you've got something blocking the conduction to the right bundle, which means it's blocking the conduction to the right ventricle. And what usually it means is that the fibers, actually the electrical activity has to go around the block. It has to go a different route, not the fastest route around the block, not the fastest route through the ventricle, but some sort of slower route around the block. So anywhere where there's a block, then there's a delay, usually a delay, and that's manifest often by a prolongation of the QRS complex. So the QRS complex is ventricular depolarization, and if it's delayed because of a block in the left or the right bundle, then you'll have a prolonged QRS complex. And then the T wave is ventricular repolarization. There's also atrial repolarization, but that electrical activity is too small to be detected on an ECG, whereas there's a lot more electrical activity in the ventricles. So ventricular repolarization, that is which happens during diastole, that is preparing the ventricle for another depolarization, another flow of electrical activity that is manifest as the T wave. So there's a couple of things that I'm sure you already know, but in systole there's contraction. So that's where after there's been ventricular depolarization, and in diastole there's relaxation of the ventricle. There's atrial and ventricular, and you can have atrial systole, which is when the atria contract, and atrial diastole, which is a passive movement. There can be both atrial and mostly systole and diastole refer to the ventricle, but of course the atria has to contract, so that's atrial systole. It's important to know so we've learned about the P wave represents atrial depolarization. The PR interval represents the SA node to the AV node. The QRS complex represents the ventricular depolarization, and the T wave represents the ventricular repolarization, and then it starts again. When you look at an ECG, then there's large squares and small squares. And we have some idea, I'm sure, that a large square is 0.2 milliseconds. So a large square is measured on the x-axis, the axis going this way. A large square is 0.2 milliseconds. So a small square is 0.04 milliseconds, because there's 5 small squares to each large square. All right. So the x-axis is time, and the y-axis is amplitude. Amplitude just meaning the electrical deflection, the extent of the electrical deflection from the isoelectric line, which is just a flat line that of the ECG. So to know those things is important background to understanding the ECG and how it works. I think the 7 steps you need to go through to read a pediatric ECG is fairly simple. You need to be able to describe the heart rate, the heart rhythm, the PR interval, the P wave morphology, the QRS duration, the QRS axis, and whether there's any evidence of ventricular hypertrophy. They're 7 basic steps. If you go through them, then you've covered a lot of what an ECG tells you. And I just want to describe, there's many different ways of identifying each of these things, but I'm just going to describe one way that I think is the simplest way. And usually what I do is get out a piece of paper and just write down the heart rate and 300 divided by the number of large squares. Remember, it's the large squares between the RR interval. So if you've got the RR interval is here, so you count the number of large squares between the RR interval, and you go 300 divided by the number of large squares. All right, so if there's 2 large squares between the RR interval, then that's a heart rate of 150. If there's 3 large squares between the RR interval, then it's a heart rate of 100. All right, so that's pretty simple. The next thing you need to do is decide whether the heart's in sinus rhythm or not. And we sometimes get a good idea of that from just feeling the pulses. You feel that the child's in sinus rhythm. And when you're feeling the pulse of a patient who's in sinus rhythm, you should feel a regular pulsation. Now, it doesn't guarantee the child's in sinus rhythm, but it probably means the child's not in atrial fibrillation, where you feel quite a regular pulse, both in time and in rate. and in volume. But to know on the ECG a child's in sinus rhythm, then there's two criteria that need to be fulfilled. One is there has to be a P wave before every QRS complex. So here there's a P wave before the QRS complex, and there's another P wave before this QRS complex. So that means there's likely to be sinus rhythm. The second criteria for being in sinus rhythm is that there needs to be an upright P wave in lead 1 and lead AVF. And all that means, it's looking at what's called the P wave axis. And all that means is that the P wave is coming from the sinoatrial node. If the P wave was coming from some other part of the atrium, either we're in the left atrium, or it was coming from down below near the AV node, if it was coming from close to the AV node, it's called junctional rhythm, but it was coming from somewhere else, then the P wave is not upright in lead 1 and AVF. Sometimes you have like a multifocal P wave where you've got a P wave upright in some of the leads and it's inverted in other leads. Then what you're likely to have is a number of pacemaker cells within the atrium firing off electrical activity that stimulate the AV node, that go from several different places node. And so if the P wave is upright in lead 1 and AVF, and there's a P wave before every QRS complex, then the child's in sinus rhythm, right? The next thing is to work out what the PR interval is. Remember I said the PR interval measures the distance in time between the sinoatrial node and the atrioventricular node, the AV node, right? And usually it's less than 0.16 seconds, right? So that's 4 small squares or less, right? It's a bit age dependent, but usually for a child up to 12 years of age, 12 or 14, it's no more than 4 small squares. All right, so you just need to know that that's 0.16 seconds or 4 small squares. Remember, each small square is 0.04 seconds. The next thing to do is look at if the PR interval is prolonged, if it's more than 0.16 seconds, then you've got some degree, like I said, of heart block. So there's something happening here in the atrium that's blocking the fast flow of the electrical activity from the AV node, so for the SA node to the AV node. If there's a block there, like a bit of scar tissue or something on the atrium, then or inflammation, then the conduction will go from the SA node to the AV node in a slower route. It'll go around the block, all right? And so there's lots of things that might cause like a heart block. For example, with rheumatic heart disease, what usually causes a heart block is not scarring, but a bit of inflammation. If you get inflammation of the atrium, then you might get first-degree heart block because the electrical impulse has to go around the area of inflammation rather than through it. Or if it's going through it, it's delayed in going through it. So you can understand the pathology that might be going on based on the ECG. All right. So if the PR interval is long, then you've got a degree of heart block. We'll talk about first and second and third degree heart block in a little while, but the main thing is to know what the PR interval is. The next thing to think about is what the P wave morphology is. Now, remember I said morphology just means shape. That's all it means. So when you're looking at the P wave morphology, it should be no more than 2 small squares in length, all right, in time, in distance, and it should be no more than 2 small squares in height, okay? And that's just when you've got a normal atrium, it will conduct the it will depolarize and conduct the electrical activity that's required from the SA node through the muscle of the atrium with minimal delay. If there's delay, then it might be there's delay because the atrium is too large. In that case, you may get a peaked T wave, or if there's hypertrophy, if it's thickened, then it'll either be a peaked P wave or it'll be a prolonged P wave. And that depends, whether it's peaked or prolonged depends on whether or not the hypertrophy is at the right or the left atrium. So if you've got right atrial hypertrophy, a really thickened right atrium, then you'll have what's called P pulmonale, which is a peaked P wave. It'll be more than 2 small squares in height. And if you've got mitral hypertrophy, left atrial hypertrophy, I should say left atrial hypertrophy, then the P wave will be prolonged, right? And so there'll be what we call P mitrale. And it's called P mitrale because if you've got mitral valve stenosis, then you'll have hypertrophy of the left ventricle. Now, if you think about it, if a child's got mitral stenosis from rheumatic heart disease or congenital mitral stenosis, then the atrium, the left atrium gets very thick, and that can prolong the P wave. If a child's got pulmonary hypertension, then, or a patient with pulmonary hypertension for whatever reason, and it's sort of chronic pulmonary hypertension, then their right atrium will be very thick, and then you'll have P pulmonale. So that's the way you can remember it. P pulmonale is a peaked P wave, and that's associated with pulmonary hypertension. P mitrale is a prolonged P wave, and that's caused by left ventricular hypertrophy. And you can see that when you've got mitral stenosis. You can see it in other conditions too, but they're the reasons why they're given that name. So you need to look at the P wave morphology and decide whether the P wave morphology is normal or whether there's evidence of right atrial hypertrophy or whether there's evidence of left atrial hypertrophy. Now, once you've done that, you've looked at the P wave, you looked at the AV, the PR interval, then we start on the QRS deflections. And again, the QRS duration should be no more than 2 small squares. Right? If it's prolonged, then it suggests again that there's some block somewhere in the electrical impulse that's going through the ventricles. Then if there's a block, then the electrical impulse goes a slower distance around the ventricle. And so the QRS complex is widened because it just takes longer for the electrical activity to go fully around the ventricle. So the QRS duration should be less than 2 small squares or less, right? And then the next thing to do is look at the QRS axis. Now, that's a little bit harder to interpret, and so I'll try to explain that in a minute. And we might do that just with some ECGs. So far, we've looked at the heart rate, the rhythm, the PR interval, the P wave morphology, and the QRS duration. And the last 2 things are the QRS axis and if there's any evidence of ventricular hypertrophy. So I just wanted to show you some ECGs now. And this is the ECG of a child who had a large ventricular septal defect. We might just go through it. So remember we said the first thing to do is look at the rate. Now, it looks to me like there's 2 large squares between the RR interval, right? Maybe just a little bit more than 2 large squares. So the heart rate has to be around about 150, doesn't it? It might be just a bit less than 150, right? The second thing we look at is the PR interval. And here you've got a PR interval, 1, 2, almost 3 small squares. So the PR interval is no more than 0.12 seconds. Remember, we said that the PR interval should be less than 0.16. We need to look to see whether it's in sinus rhythm or not. And so remember I said there are 2 criteria. You need an upright P wave in lead 1 and an upright P wave in lead AVF. And remember I said that tells you that the P wave is coming from the sinoatrial node, right? If it was upright in one and down in the other one, then it might the P wave, the pacemaker might be coming from somewhere else, like in the left atrium or closer to the AV node. And the second thing we said for it to be sinus rhythm is that there has to be a P wave before every QRS complex. And so you can see on the rhythm strip here, the P wave QRS, there's a consistent P wave before every QRS complex, and the PR interval is normal between every QRS complex. So far we know this is in sinus rhythm. It's a heart rate of around about close to 150. All right. The next thing we said was the PR interval, which we've looked at. This is 0.12 seconds. And then we said we'd look at the QRS duration. Now, if you look at you can usually eyeball these fairly well, and you can see that the QRS duration, it looks less than 2 small squares, doesn't it? It's quite a narrow QRS complex. It's not more than 2 small squares, so it's quite narrow. So that suggests that there's no evidence of ventricular block. There's not a right or a left bundle branch block because the the QRS duration is normal, right? Then we said that to look for, well, I think that's all we've done, isn't it? Yeah. The P wave morphology. We said when you're looking at the P wave morphology, you need to look to see whether the P wave is less than 2 small squares in duration and less than 2 small squares in height. And you can see that this P wave, all the P waves are around about 1 to 2 millimeters in length and 1 to 2, probably 1 millimeter in height. And so that there's no evidence of left or right atrial hypertrophy. The next thing is to look at the QRS axis. And to look at the QRS axis, you need to look at lead 1 and lead AVF. And the way you do it, hang on, let me see if I've got we'll just go through this. As I said, the heart rate is 300 divided by 2, so it's 150. It's in sinus rhythm because there's a P wave in lead 1 and AVF. The P wave morphology is normal, that is less than 2 seconds, both in length and less than 2 milliamps in height. The QRS duration is less than 2 small squares. Well, it's around about 2 small squares. And now we'll talk about the QRS axis next, perhaps. What you do is count the net deflection from the isoelectric line in both lead 1 and AVF. Now, I'll explain what that means. This is lead 1, and so when you're looking for a net deflection, that means if you add up the R wave and then add up the S wave and subtract one from the other, then you've got a net deflection, and you can see in which direction that is. So I explained it. So this one, it looks like the R wave is going up 3 millimeters, right? It looks like the S wave is going down maybe 6 millimeters. So the net deflection is -3. Okay, so there's a 3 in the negative direction. For AVF, you've got a deflection down here of only about 3 millimeters, right? And you've got a positive deflection of 5, 10, 15, 20, 21 millimeters. So if you subtract 3 or 4 from 21, then you get, say, 17 in the positive direction, right? So this is important to understand, because when you draw a vector, right, to understand the axis, you need to draw a vector, and I'll just show you that. So this is a vector. Remember, we said the QRS deflection in lead 1. If you draw a vector of the heart, then this is lead 1 and this is lead AVF. And I usually just draw it manually, just like I've done here. And the net deflection in lead 1 was negative, wasn't it? -2 or -3. And the net deflection in lead AVF was positive. So this is positive down here. This is positive this way. So this going back from here is minus. All right. So the net deflection in lead 1 is negative, -2. And the net deflection in lead AVF is positive. So it's coming down here, +17. So that's all you do. It doesn't have to be exact. You try to do it as exactly as you can by just using your eyes and just writing it down. But if you think that the net deflection is 17 down and -2 across, then it must be in this axis. It must be in this quadrant, I mean, and it must be just past 90 degrees. So it's probably about 100 degrees, all right? So a little bit past the AVF. So when you, excuse me, I'll just have to get this. When you look at the QRS axis, then most of you know from adult medicine that the QRS axis for a normal adult is somewhere between 0 and 90 degrees. For a child, it can be a little bit further around, and it can be a bit further around. It can be anywhere in this quadrant. It can also be between 0 and 90 degrees, but anywhere between 0 and 180 degrees. And as the child gets older, then the axis progressively moves around to what we think of as the normal quadrant for an adult, between 0 and 90 degrees. And the reason when in young infants it's a little bit right axis deviation is simply because that a baby at the time of birth has no difference in terms of the dominance of the right or the left ventricle. It's only after the birth that the left ventricle becomes more dominant, all right? Because before birth, the ventricles are functioning in parallel, not in series. And it's after that the duct closes and the pulmonary vascular resistance drops. Therefore, the systemic vascular resistance is higher than the pulmonary vascular resistance. So the left ventricle becomes more dominant, becomes more hypertrophied and larger. So there's often a right ventricular predominance at the time of birth, and then that progressively changes quite quickly, actually, usually in the first few weeks of life. And then, but some children can have an axis that's beyond the 90 degrees, even in the first year of life. This is the typical axis. Again, at 1 to 3 months, the average is 70 degrees. So it's still in the 0 to 90 degree quadrant, but it can be anything from +10 to a +125. So +10 here to 125 would be around about here. That can be normal. And it progressively comes back to normal as the child gets to being older and being an adult. Okay, so we talked about the QRS axis. This is the same ECG of a child who's got a ventricular septal defect, and we talked about the QRS axis and the QRS duration. And now the last thing we need to look at is for evidence of ventricular hypertrophy. And I'll just go back to those rules I mentioned at the start. I didn't go through these, but to know whether a child's got ventricular hypertrophy, you simply look at V5 and V2. And if you want to know, well, I should explain, when lead V2 is looking at the left ventricle, V2 is, remember, V2 is one of the chest leads, and V2 goes in about here. So that's looking at the right ventricle, directly down on the right ventricle. V5 is out here, isn't it, when you put the leads on, and it's looking at the left ventricle, usually looking at the apex of the left ventricle. And so when you are thinking about whether there's ventricular hypertrophy, then look for the R wave in V5, because that left ventricular hypertrophy, the R wave is depolarization. So you're looking at how large the R wave is in V5 and how deep the S wave is in V2. Remember, it's the R wave that is looking at the depolarization of that particular ventricle. Right? I'll maybe explain that a bit more. But when you're looking at, say, V2 here, the R wave is looking at depolarization of the right ventricle, V2 being more central, and in V5, the R wave is looking at depolarization of the left ventricle because it's around laterally. Similarly, the S wave in V2, you can see it down to about here. So it's a fairly deep S wave. The S wave is looking at depolarization of the left ventricle, right? Because it's a negative deflection that's looking at the left ventricle. And similarly, the R wave in V5 is looking at depolarization of the right ventricle. It takes a bit to get used to that, but knowing about the lead placements and knowing what ventricle that particular lead is looking at helps you in understanding this. But if the R wave in V5 plus the S wave in V2 is more than 35 millimeters, right, then there's left ventricular hypertrophy. And if the R wave in V2, remember the R wave is looking at the right ventricle and the S wave in V5 is looking at the right ventricle, if that's more than 35 millimeters, then there's right ventricular hypertrophy. And you can just look at this. If we look at looking for evidence of left ventricular hypertrophy, then the R wave is 5, 10, 15, 20, 25, 28, 28 up, and 5, 10, 15, 20, 28 up here. And then so RV5 plus SV2, so 5, 10, 15, 20. So 25 plus 20 is 45. So when you add those two together, then you get if there's evidence of left ventricular hypertrophy. So 45 deflection of RV5 plus SV2 is likely to be evidence of left ventricular hypertrophy. And the same with right ventricular hypertrophy, the R wave in V2, 5, 10, 15, 16, 17, 18, plus 5, 10, 15, 20, 28. 28 plus 18 is 46. So again, there's evidence of right ventricular hypertrophy. So this child is a child with a large VSD who's got evidence of biventricular hypertrophy. All right. Okay. Okay. All right. Well, that's most of learning about reading the ECG is the things that I've just mentioned. But I want to show some examples now of some ECGs, and maybe we can go through some. When you look at this, again, you can see that if you look at how many large squares there are between the RR interval, you've got 1 square, 2 squares, 3 squares. So it's probably about a rate of around about 100. You've got sinus rhythm. Is the sinus rhythm? Well, there's a P wave before every QRS complex. So there's evidence of sinus rhythm. The PR interval is 1, 2, 3, 4. It's all of four small squares. So the PR interval is probably 0.16 seconds. Remember we said anything 0.16 seconds or less is evidence of this being sinus rhythm. So there should be a P wave before every QRS, and the P wave should be upright in lead 1 and in AVF. So the child's in sinus rhythm and the PR interval is within the normal limits. We said that the QRS complex should be less than 2 small squares. And here you can see that it looks a bit larger, doesn't it? Because it starts here, 1, 2, 3. It's 3 small squares for the QRS complex. Remember I said if there's a widened QRS complex, then there's probably some block in ventricular conduction. And then the question is, where is the block? And remember I said that lead 2 looks at the right ventricle, directly at the right ventricle, and lead V5 looks at the left ventricle. And you can tell whether there's a left or a right bundle branch block by looking at the lead 2. So lead 2 has this RSR pattern, whereas lead V5 is just a normal QRS complex, isn't it? Just normal. So this child's got a right bundle branch block because there's prolonged QRS complex, and because the RSR pattern, this R wave, deep S wave, R wave again. that is in lead V2. So therefore, it's a right bundle branch block. So already we know that this child's got a right bundle branch block. And we didn't talk about the P wave morphology, but remember we said that the P waves should be no more than 2 millimeters wide and no more than 2 millimeters in height. And here we've got a P wave that looks like it's 1, 2, 3 millimeters in height. And so remember I said if it's a peaked P wave, then that's called P pulmonale, and that's evidence of right atrial hypertrophy. So already we know from reading this ECG, it's in sinus rhythm, there's evidence of right atrial hypertrophy, and there's evidence of a right bundle branch block. Right? And when knowing that, you can get some idea of what the pathology might be. Right? Because if you've got a child who's got right atrial hypertrophy and a right bundle branch block, you're starting to think maybe there's something going on with the right side of the heart. You know, could it be a tetralogy of Fallot, or could it be some other problem, perhaps a cardiomyopathy with thickened right ventricle? It could be, there's lots of different things could be happening, but you can get an idea of, from the ECG, where the pathology is in the heart. You can clearly see it's in the right side, it's involving the atrium and the ventricle, because you've got a right bundle branch block and you've got P pulmonale. Right? Could be the child's got pulmonary hypertension, like chronic pulmonary hypertension, that's led to P pulmonale and has led to a right bundle branch block because it's led to right ventricular hypertrophy. There's lots of different things that could be going on, but from the ECG, you can sort of then start to think, well, which part of the heart is affected by this ECG, by the pathology. Okay. All right, we might go through a few more of these. Here, you've got 1, 2, 3 small squares. So again, the rate is just over 100, just under 100, I would say. It's just over 3 small squares. So say 3.2, 300 divided by 3.2 is around about 95. So the rate's about 95. Is there a P wave before every QRS complex? Well, there is. There's a P wave here, and it's upright in lead 1, and in AVF, it's still upright. They're small P waves, but they're there. They're present, aren't they? So this is it sinus rhythm? Well, sinus rhythm has to have a P wave before every QRS complex, and there has to be an upright P wave in AVF and in lead 1. And there is, so it's in sinus rhythm. Is there a prolonged PR interval where you've got 1, 2, 3, 4? There's four full small squares, isn't there? So it's the maximum PR interval that there really could be. Sorry, excuse me, I'll just get that. Yeah, what are we up to? Yeah, this is, so it's sinus rhythm, and there's not a prolonged PR interval, but a normal PR interval that's the upper limit of normal. The next thing is the P wave morphology, and you can just tell by just looking at this that the P wave morphology is neither peaked nor is it prolonged. So there's no evidence of atrial hypertrophy on this ECG. Next thing is the QRS duration, and here you've got 2 small squares, right? So probably the QRS duration mostly is normal. It looks a bit prolonged here, doesn't it? So 1, 2, it's probably still 2 small squares in duration. Maybe a little bit, maybe getting a little bit longer here, right? So you've got a child who's in sinus rhythm with a normal PR interval, no evidence of atrial hypertrophy, who's got a slightly prolonged QRS duration here. Now, then we look to see if there's any RSR pattern. It's not very clear, but there's a little bit of a strange deflection of the QRS, the S wave here. So there might be something going on in this ventricle. And then we look to see if there's any evidence of ventricular hypertrophy. So remember I said that if we're looking for right ventricular hypertrophy, it's the R wave in V2. So it's only 7 millimeters up. So it's not going to be, it's unlikely to be right ventricular hypertrophy. So 7 plus 10 is only 17. So there's no right ventricular hypertrophy. But if you look at left ventricular hypertrophy, remember it's the R wave in V5. So 5, 10, 15, 20, 25, 30. That's quite tall, isn't it? 30 millimeters, the R wave in V5. And the S wave in V2 is 5, 10, or almost 15. So we're up to about 40 millimeters. So it looks like there's left ventricular hypertrophy, but no right ventricular hypertrophy. So really all we found in this ECG, it's in sinus rhythm. The rate's a bit less than 100, probably 90. It's a normal PR interval. There's no evidence of atrial hypertrophy, but there is evidence of left ventricular hypertrophy. So that's all you could say from this ECG. But again, it tells you, it gives you a bit of a clue as to where there might be pathology within the heart. If you've got left ventricular hypertrophy, then it might be that there's some pathology in the left ventricle. Like lots of reasons could be for that. Like if you've got a left to right shunt that's putting where there's more pressure on the left ventricle, if you've got aortic stenosis, which causes hypertrophy of the ventricle behind it, if there's systemic hypertension that leads to a hypertrophied ventricle, lots of reasons, and you can't tell from the ECG which one it is. You can't tell that. What you can do though is tell which part of the heart there seems to be a problem, right? And that's really the way you look at ECGs. Okay. This ECG, again, when you look at this, there's 1, 2, almost 3 small squares. So the rates are between the RR interval, the rate's about 100. There's a P wave before every QRS complex, so you know it's in sinus rhythm. The P wave is a bit interesting, isn't it? It looks like about 2 small squares wide and 2 small squares high, so probably not evidence of atrial hypertrophy. The QRS, the PR interval, it looks like no more than 3 small squares. So I think it's safe. There's no prolonged PR interval there. But when you get to ventricular hypertrophy, it looks like things are rather deep here, aren't they, in V2? So 5, 10, 15, 20, 25, 30, 35. It's hard to see the end of it. So it's about 30 deep in V2. Remember, the S wave in V2 and the R wave in V5 is looking for left ventricular hypertrophy. So 5, 10, 15, 20, 25, 30, at least 30. So you've got RV5 plus SV2 is around about 60. So there must be left ventricular hypertrophy. And then the question is there also right ventricular hypertrophy? Let's see, V2, it's a bit hard to see, but 5, 10, 15, 20, 25, 28 maybe, and the S wave in V5, it's almost nothing. So there probably isn't right ventricular hypertrophy, but there certainly is severe left ventricular hypertrophy in a child who doesn't show any evidence of atrial hypertrophy, although maybe the P waves are a little bit high, but probably not. And then we should look at the QRS axis in this ECG because it's a bit easy to do. So remember, we said you look at the net deflection in lead 1 and lead AVF. So this net deflection is 5, 10, 15, probably 20 up. There's nothing down, so it's about 20 up. So it's in a positive direction. And in AVF, you've got some up and some down. So you've got 5, 10, maybe 15 up and about 5 down or 4 down. So that net deflection, therefore, is, say, 9 in the positive direction. So you've got a positive deflection here of 20 and a positive deflection of 9. And if we go back, I'm not sure whether I've done it. No. Just go back to the axis. If you've got 20 in the positive direction here and 9 in the positive direction here, then you know that the axis is somewhere in the quadrant between 0 and 90 degrees. And it's going to be round about 60 degrees, right? So it's a normal QRS axis for that ECG. Yeah. Okay. So this is an ECG of a child who's got left ventricular hypertrophy. And as I said, the causes of that could be many things. And you can't say what the cause is, but you can say what part of the heart is affected just from looking at the ECG. And then usually what you want to do is obviously take a history and do an examination and see if there's any murmurs and see what the blood pressure is. And you can put it all together and really get a good picture of what part of the heart is most likely to be affected. We might not do this one. I wanted to just, towards the end, I wanted to just touch on a couple of other things that you need to know about. And this is one. So we've talked about a sort of normal ECG and abnormalities related to hypertrophy of the atria or the ventricles. This is a bit different. And remember we said when you're looking at ECG, the first thing is the rate. So look at the rate. It's 300 divided by the number of large squares. So you've got only 1.5. So at most, you've probably got a rate here of around about 200, isn't it? About 200 per minute. Now, then the next thing to ask is it sinus rhythm or not? Can you see a P wave before every QRS complex? It's a little hard to see those P waves, isn't it? All right. Mostly they're absent. All right. I should say the rate is 200. Then the question you ask is can you see P waves? And is the QRS axis the QRS duration, is that normal or wide? They're the two things you ask. If you see a tachyarrhythmia like this, are there P waves? If there are P waves, then you've got sinus tachycardia. If there aren't P waves, then you may have some other form of tachycardia. If the QRS duration is normal, if it's a narrow QRS, then it must be supraventricular. And if the QRS duration is prolonged, like wide, if the QRS deflection is wider, then there must be some block or some aberrant pathway in the ventricles. So I'll just go back to the first thing I was talking about, which is, just to explain the difference between supraventricular tachycardia and ventricular tachycardia. So if you've got some pacemaker that's firing off very rapidly in the atrium, that's supraventricular in the atrium. It's firing off very rapidly in the atrium, and it's hitting the AV node, and then it's stimulating the AV node, and the electrical impulse then goes down the right and left bundle and into the Purkinje fibers. So it follows the normal path through the ventricle, but it follows an abnormal path through the atrium, right? And usually when you've got a supraventricular tachycardia, you won't see P waves, and you won't see P waves because the pacemaker cells that are firing off are usually very close to the AV node. And if they're really close to the AV node, then there's not any distance between that the electrical impulse has to travel to get to the AV node. It's sometimes the pacemaker is actually at the AV node itself. And that's why you don't see P waves. And that's why you also see a normal QRS complex. The QRS complex is narrow because once it's got to the AV node, once the electrical impulse has got to the AV node, then it's following the normal pathway around. It's not following a slow route, right? Whereas if a child's got ventricular tachycardia, then it starts somewhere besides the AV node. There's some pacemaker cells or some scarring or something that's stimulating an electrical impulse that's in the ventricle, starts in the ventricle, and it goes around a slow route around the ventricle. It doesn't go through the left and right bundle and through the Purkinje fibers. It finds it some other route around that joins up the nerves within the heart. All right, and that's why in ventricular tachycardia, the QRS complex is wider because it's going a slow route. All right, so we'll just go back to that. The child who's got SVT, and here it's very hard to see P waves. You can't see a normal P wave before every QRS complex. So you're starting to think this could be SVT. And the second thing is, what is the duration of the QRS complex? And it's around about normal. It's not more than 2 small squares. It's like 1 to 2 small squares. So you're then starting to think this is a narrow QRS complex. The QRS is normal, so therefore it's probably SVT, right? Okay. I think making a distinction between SVT, supraventricular tachycardia, and ventricular tachycardia is a good thing to learn, right? So let's talk about this. Oh, yes. This is getting a bit more advanced, but once you've made a diagnosis of SVT, then you're always asking the question is, why is the SVT? And sometimes you can't work that out. Sometimes it's idiopathic. Sometimes it's just little pacemaker cells around the AV node. But sometimes there's a condition called Wolff-Parkinson-White syndrome. And the main thing is when you revert the child to sinus rhythm, then look to see if there's this thing called a delta wave, which is a slurred upstroke on the R wave in all the R waves. This a little bit more advanced, but I think today I'd just like you to know the characteristic features of supraventricular tachycardia and ventricular tachycardia. All right. Remember, supraventricular tachycardia, you can't see P waves, and the QRS complex is narrow, like normal. And in ventricular tachycardia, the QRS complex is wide, because there's a pacemaker that's starting somewhere besides the AV node and going a slow way around the ventricles. Okay, so this is another child who's got tachycardia, again about the same rate, but if you look, it's hard to see P waves again. They may well be there, but the characteristic feature of this is that the QRS complex doesn't look normal, does it? It looks wide, very wide, right? So the QRS complex, we said less than 2. Well, it's probably about 5, each of them maybe 6, and 1 goes into the next one, doesn't it? Looks very different to this, where you've got a narrow normal QRS complex, right? Here, there's a wide QRS complex. So this is ventricular tachycardia. Somewhere in the ventricle, there's a pacemaker that's firing off at a rapid rate that is then the electrical activity is flowing around the ventricle in a slow way. It's getting there the fastest way it can, but from a different starting point, not the AV node. And so therefore, this is ventricular tachycardia, okay? Again, when you see a child with ventricular tachycardia, you've also always got to ask the question why, and it might be they've got electrolyte disturbance, or it might be they've got inflammation of the ventricle, like with rheumatic heart disease, or something like that, hypomagnesemia, very low magnesium levels, or hypokalemia. They could all give you that. This is a particular type of syndrome. Again, I won't go through this, a bit like Wolff-Parkinson-White syndrome, where when you revert the child to sinus rhythm, again, this is the child's back in sinus rhythm. You can see the P waves and the QRS complex. Still, the QRS duration is very wide. This is a condition called Brugada syndrome, where you've got still a persistingly wide QRS complex in the QRS leads. This is called Brugada syndrome, and the characteristic feature is this shape of the QRS and the T waves, like where the QRS flows into the T wave. You've got sort of ST elevation here. I don't think you need to worry about that, but again, to know the distinction between SVT and VT, because the treatments are quite different from SVT to VT. We'll talk about treatments and things at a later date. I just want you to be able to identify these characteristic changes today. But the first one I showed you was SVT related to Wolff-Parkinson-White syndrome. You don't know that until you've reverted the child and you see the slurred upstroke, the delta waves. And the next one was ventricular tachycardia related to Brugada syndrome. But again, you don't know that until you've reverted and you can see the characteristics. But it could be with either of them, SVT or VT, that the major problem is electrolyte imbalance, hypomagnesemia, hypokalemia, those things. So fix those things first and then see what the ECG shows. Okay, this is another child who's got Brugada syndrome, different child with ventricular tachycardia. You can see the widened QRS complexes. And again, the characteristic of the ECG, once the child's reverted, you can see this slurred upstroke on the like ST elevation. Again, it could be other things, but this is Brugada syndrome causing ventricular tachycardia. Don't worry about that, but just be able to try to recognize what VT looks like and what SVT looks like. Okay. This is again Brugada syndrome. I won't show you, but the Brugada syndrome is a cause of SVT, of ventricular tachycardia, VT. Okay, but remember that's a bit advanced. I'll finish now, but I just want to go back to where we started, and that is the 7 steps to reading a pediatric ECG. Obviously, you can get more and more complex. You can go into more and more detail, but if you know the heart rate, how to calculate the heart rate, what constitutes sinus rhythm, what the normal PR interval is, P-wave morphology, the QRS duration, the QRS axis, and know how to calculate that by drawing a vector, and to know how to identify ventricular hypertrophy, and then to know how to distinguish atrial tachyarrhythmias from ventricular tachyarrhythmias. That's a really good start in reading a pediatric ECG. So I think we might stop there. That's a lot of things we've talked about today. If you practice by looking at some ECGs and trying to read them and write down all those things, I think that's the way to learn how to read a pediatric ECG. So that's all I wanted to say today, but I hope that's been useful. I'll just stop the recording and happy to answer any questions. There's lots more we can say about pediatric cardiology and about reading ECGs, and I guess the connection we can make between the clinical things and ECGs and chest x-rays. That's how we need to put it all together. But today I just wanted to give you the basics of reading an ECG.